Hello, hello. Hello, hello. Hello. We are live. A little bit of technical difficulties. Good to be here. Um, Gonna just give a moment to let people sign on, but I'm Ken and Celtic, Dr. Celtic, But got some folks signing on now. All right. Looking good. Welcome, welcome. Dr. Celtic here. Hello, thank you for coming. Hello, everyone. All right. We're going to wait just a moment before I kind of get started introducing myself and talking about what we're here to talk about today. But just kind of giving a moment for some folks to sign on and join us. Welcome. All right. All right. Thank you for everyone for coming. Just taking a moment to let folks sign on. All right. Thank you, thank you. Ken and Celtic here. Thank you for joining our Ask Me Anything. Appreciate it. You can already start submitting your questions if you've got something on your mind you want to ask me. Thank you. You are not the only one. There's more than one to poster. Just take a moment. We're just waiting for everyone to kind of join slowly. It's an active process. This is our learning the Facebook Live. Optimizing everything. People are rolling in. I appreciate it. Welcome, Dr. Celtic here. All right, thank you. See more people coming in. Thank you so much. Excited to have you all here. If you have a question, it's burning a question in your mind, please take some time to type out a question now. I'm gonna kind of, I have a plan that we'll talk about some stuff, but questions are what we're here for. So if something's, you already got your question in mind, feel free to drop it in the comments. What categories are coming? Yeah, I mean, my plan is to talk about anything and everything feminizing bottom surgery, to details about the procedures, different types of procedures available, talk about what's aftercare like, what do you need to do preoperatively, what's a consultation look like. I mean, truthfully, anything along the timeline, from before your consult till when you graduate from us, a year after surgery, or any sort of question you may have heard and you're not certain if you heard it from, you want to hear it from a surgeon, hear my take on it. More than happy to answer anything and everything. Thank you everyone for signing on. All right. Well, appreciate everyone for signing on. Anyhow, I'm Ken and Celtic. Nice to meet y'all. We've got a link here. You can scan the QR code. It's present on all the pages behind me. Hopefully it's scannable to schedule a consultation, or if you have any questions, feel free to use our any of our socials, which are listed here. Email us. Reach out on our website if you have any sort of questions about anything and everything. And to be quite honest, we're all here. We're here to help and look forward to meeting any of you and all of you. All right. So before we kind of dive into talking about bottom surgery, I just kind of want to give you a background of who I am. My name's Ken and Celtic. I'm here at the. So before we kind of dive into talking. Sorry, technical. My name's Ken and Celtic. I'm a California native. Grew up here. I'm here now at the Crane Center in California. So we're based out of the San Francisco Bay Area. But anyhow, I went to UC Berkeley, just across the bay here in Northern California, for my undergraduate degree. From there, I went to Columbia University in New York City, where I studied nutrition and did a Master of Science. I'm studying nutrition. Thereafter, I went to medical school in Long Island at Hofstra North Shore LAJ, where I discovered urology. And so I traveled to Houston, Texas. I went to Houston Methodist for my urological surgery training. learned robotic surgery there, learned the foundations of reconstructive urology, as well as every part of urology. From that point on, I actually, while I was there training, I had made some connections and talked to the team out at Crane Center, Texas, in fact, in Austin, Texas. I drove back and forth from Houston to Austin many times during my time in Houston. Had opportunity to work with all the surgeons out there and learn from the best. And then after that, I went to Mount Sinai in New York City, where I did my fellowship in reconstructive urology and gender-affirming genital surgery. And then I came here to Crane Center, California. So now we've got more people in here, and I do see your question, and we will dive onto that. I just want to briefly kind of talk about what could fall under the umbrella of gender-affirming bottom surgery, transfeminine type procedures. It could be everything from orchiectomy, which involves the removal of the gonads. It's a minimally invasive surgery. It's often done as same day surgery. You go home the same day. Minimal downtime. Minimal need for even much medication. Often people are able to manage their pain with just over-the-counter type medications, and it's awesome. I mean, it gets you off. If you're taking spironolactone, potentially gets you off that. Working with your hormone provider. And it also doesn't burn any bridges if vaginoplasty is in your future. Often when people talk about feminizing bottom surgery, the hallmark procedure is often thought of as vaginoplasty, which comes in many flavors. On here on the screen you might be able to see ranges from everything like minimal depth vaginoplasty, also called zero depth, or vulvoplasty. Procedures like the gold standard, which would be like the penile inversion vaginoplasty. Other types of vaginoplasty are intestinal vaginoplasty and robotic peritoneal flap vaginoplasty. More than happy to talk about all of those today. But you're already getting some questions, so 1 second, let me take a look. Had a question from the commenter, asking about weight with regard to surgery. We do, using weight is an important metric for kind of understanding how people will heal and understanding surgical risks. So, there are surgical risk factors that can increase with higher BMI is the metric that's often used in the literature to describe, people's risk factors with regard to weight. And it's something that we use as well. And there's data, both in all types of surgeries that we know that, people with higher BMI might have higher, portends a higher risk for wound complications, poor healing, wound infections, and others. There's also risks, technical considerations with regard to, body habitus, size, that are related to technique-specific type parts of the procedures that can be technically challenging or impossible depending on BMI. And so this is definitely something that if you were to have a consultation with me, I mean, it's definitely one of the metrics that we use to find the technique, surgical option that's the best for you. And so, great question, and happy to, and I see, kind of a further question is like, should you wait or have the consultation now? More than happy to have the consultation now. We can make a plan now. We're here to work with patients wherever they're at in their journey, and whatever that timeline looks like. We're here to make a plan for you at an individual level. So definitely good question to bring up during your consultation. Good question, thank you. So kind of in describing these techniques, there's many techniques available. The vulvoplasty or zero depth vaginoplasty or minimal depth vaginoplasty, these are largely the similar or the same techniques. It involves creating all of the features of the external vagina, using tissues that are available externally currently, to create labia majora, labia minora, clitoris, clitoral hood, recessed vaginal vestibule, moving the urethral opening to the right location, and then creating some sort of appearance of where the vaginal canal would be or could be. So this is a technique that's for people that are not interested in receptive vaginal intercourse, because after this technique, which is the minimal depth vaginoplasty, receptive vaginal intercourse is not a possibility. With that being said, there's every intention to maintain the sensation of the labia and the clitoris, so sexual satisfaction is still possible. It's just this is a less invasive surgery. It has less risks because you don't have to create the canal. You're removing a whole portion of the procedure. So for the right person, it's the best procedure possible. And for certain people, it's not even in something that they're interested in. So kind of moving on to the rest of the techniques, which are ways to create a full depth vaginal canal. The gold standard being the penile inversion vaginoplasty, which again involves creating all those features of the external vagina in one trip to the OR. So in one day we're creating labia majora, labia minora, clitoris, clitoral hood, recessed vaginal vestibule, moving your urethral opening to the right spot, as well as creating a full depth vaginal canal. In this case, using external skin that you have available right now. Often the lining with my technique, the lining of this would be lined with the shaft skin that's available, and then the depth of the vagina is lined with the scrotal skin that's removed on the very first part of the step. With all of these techniques, orchiectomy is part of the procedure. So in order to create the labia majora, in the proper form, we remove both testicles or gonads. And at that point, prior to that point, family planning has to be taken care of. So definitely something that has to be thought about or taken care of prior to that part. But yeah, so that's penile inversion vaginoplasty. So I have another question from the comments. A question about BMI. Saying what do BMI is obviously not a perfect metric. I mean, I think it doesn't take a physician to know that, and within the physician medical community across not just surgeons, not just urologists, but across the board, the merits of, or the faults rather, of BMI are well documented. It's definitely something that is a gap in the medical literature. With that being said, it's also the basis for a lot of research, and so the problem is a lot of the data that talks about wound complications when you're above 30 or above 35 BMI, it does not distinguish between percentage lean body mass versus adipose. So the data doesn't differentiate on that regard. So it's challenging to counsel patients with that regard. But nonetheless, having less adipose and having more muscle mass and having that tip the scale in one way is something that we definitely have to kind of assess and discuss during a consultation. But yes, the reality is that having higher lean body mass relative to adipose would portend less kind of wound healing complications than someone whose ratio is flipped, less lean body mass and more adipose. But again, these are complicated surgeries and take a very individualized, personalized approach to ensure that you get the best surgery for you at the best time to ensure that you have the outcomes you're looking for and that you can have the best success with surgery. Great question, thank you. As people are joining, I'm Dr. Celtik, reconstructive urologist here at the Crane Center, California. Thank you for joining. If you have questions, feel free to drop them in the comments. I'm kind of talking for a little bit, kind of on some prepared stuff, but as questions arrive, I'm very happy to kind of take a moment and stop and answer those questions. So I see another question in the comments, asking about, saying, is it wrong for me to be concerned with vaginal depth? That is something that scares me. I don't understand how to know how much depth to expect. Great question. I mean, depth is important to a certain extent. So for some individuals, huge amount of depth is very important to them on an individual level. But depth is depth is an individual, personal question, that you'll have to kind of answer on your own. What to expect with regard to depth, for depending on the technique. So again, rewinding back, the minimal depth or zero depth vaginoplasty, vulvoplasty, you see on the board, kind of the top option up here. That one entails zero depth. So if you're choosing that depth, you're gonna have zero depth. So depth is not even on the table. Now, going down to the, obviously the more full depth techniques, talking about PIV, peritoneal flap, or intestinal vaginoplasty. The depth depends on many factors. Depends on the amount of lining tissue available, which the amount and type of lining tissue varies on all three of these full depth techniques. Likewise, the size of your pelvis, the size of your individual body is going to dictate a huge part of the possible depth. Even in techniques that bring in additional tissue, such as intestinal vaginoplasty or peritoneal flap vaginoplasty, where we're bringing in internal tissue that already exists inside your belly to add additional tissue to augment the depth. Even in those techniques, if you have a smaller pelvis, you're just not going to be able to accommodate whatever a very large depth, just because that's your individual anatomy. Likewise, so that's an important piece of it, is just kind of understanding that your bony structure is going to dictate a big part of it. It doesn't matter how much tissue is available, because there's also a geometry issue, in having a functional canal. Your canal can't be, overly banana shaped, or like kind of turning in a challenging direction, because then it's just this unusable space. Likewise, if you can't dilate, which is an important part of any sort of postoperative care for any vaginoplasty technique, if you can't dilate to the full depth, you won't be able to maintain that depth, and it will go away. You'll have what's called vaginal stenosis, which is the loss of depth that your body is kind of reducing in that way. So that's another piece of it. So depending on the technique also matters. So if there's not if the amount of tissue available externally is limited, then sometimes using these augmented type vaginoplasty techniques, intestinal or peritoneal flap, allows for greater depth, or the ability to augment depth. So it depends on what factors are the limiting factors, and it also depends on kind of your expectation for what your goals with regard to depth are. But with that being said, most people have, depending on body habitus, 5 to 6 inches of depth is a pretty kind of ballpark standard, depth that most people attain. Great question, appreciate it. Exactly. Sorry, I answered the question after just reading it very quickly. The question, or the statement question was, so basically the same limitations that most cis women have. Yes, exactly. Everyone has a different body. Everyone has a different pelvic anatomy. And yes, and quite honestly, I'd say that, 5 to 6 inches of depth exceeds what most natal vaginas have for depth. Initially the difference being, at least initially, is that a natal vagina has stretch. So even though it's smaller, less depth at the outside, it has some stretch. Where initially after surgery, after vaginoplasty surgery, your depth, like I said, 5 to 6 inches, and initially there's going to be a whole healing process taking place. This is a massive surgery, both inside and out. So you're going to build scar tissue around your vaginal canal, and you can do all sorts of healing processes going to take place. Initially, you're not going to have that stretch. You're not going to have that ability to flux. Like your vaginal canal will be kind of fixed in its depth. But fast forward some number of years later, as the tissue softens and everything moves forward, the canal will have stretch and will have ability to stretch and accommodate in a different manner. And so, but that takes time, and over a long period of time. We're talking years rather than weeks or days or months. Great question. Okay, tons of questions out here. Great. Feel free to take a look at the comments. We have discount code KCAMA. If you'd like to, get a discounted consultation, I'm more than happy to, please use that code. Another question, is hair removal needed before vaginoplasty? The areas where hair removal is basically mandatory are the tissues that might become invaginated, right? There's much of the external tissue that is going to remain external after surgery, and then you have the option to continue hair removal or not continue hair removal after surgery. But the areas that matter the most are the ones that could potentially become invaginated, or at least become into a more private area of your body that maybe you wouldn't want your electrologist doing hair removal for you. But yes, typically people spend some length of time. Hair can be frustrating. Places where you want it to stay, it will go, and places where you want it to go away, it tends to be kind of resistant and stay. So, it can be a bit of an annoyance and a part of the kind of preoperative process that's important to take care of, because once the tissue is invaginated, you won't have access to it, so hair removal won't be able to be done. If there's excessive intravaginal hair, it could be an infection risk, and also potentially affect the cosmesis if that's not something you're interested in. So yes, hair removal is part of the process. Great question. How much time do we need the patient to recover from surgery? It's highly variable. What I'll say is, the day after surgery, I always tell patients it's boot camp. Get you out of bed, walking around. So the day after surgery, you'll be up and walking around. Sometimes even the day of surgery, but always the day after. And then from there, you're walking every day. It's part of the kind of the prescription. Walking multiple times a day. For many minutes, making sure you're moving your legs, as from a surgical standpoint, that's an important piece. But functionally, you're back up and moving around, doing regular things, walking around, and from the day after surgery. So you'll be up and moving around, as that. It depends on what you define as recovery. But the reality is pain is relatively minimal. People. Minimal is not correct, rather. It's a major surgery. It hurts, but it's surprisingly less than most people expect, I think, is a better way to say that. Sorry. It's definitely not a minimal. It's a intra-abdominal or pelvic surgery, or a combination of the both. But people handle the pain very well, is really what I'd like to highlight. Is like, in spite of being a very big surgery in a very sensitive area, people tolerate surgery like impressively well. I'm continuing to be impressed by patients. So people do really well. It's not uncommon for me to have patients at 2 weeks post-op saying, "Doc, like, I'm feeling pretty good," and feeling like surprised or like guilty about it. But it's just kind of, it's just individualized to each process. But you'll be up walking around. I tell patients, don't lift anything heavy or push or do any vigorous exercise, at least for the first 8 weeks, to let everything heal. Both in the pelvis and the abdominal wall if it's a robotic surgery. And then, often hold off from sexual intercourse until you're entirely healed, which often, I'm very conservative in that regard. I want everyone to be super, super, super well healed before they move, so I tell them to hold off until about 3 months. But great question. I see some other questions coming in. Alrighty. In post-op, when should I expect to be move relatively comfortably? Yeah, that's a good question. The day after surgery, you'll be up moving around. Definitely is not going to be something you're going to say is comfortable. But by that first post-op visit, patients are walking in, maybe a bit slower than they were before pre-op, but people are walking in on their own, carrying their catheter on that first post-op visit. And often, and it's not uncommon for patients to even be off any sort of like narcotic medication, just using Tylenol. So I'd say within a week or so, potentially. But again, everyone's different. Another good question's coming in, what's the best surgery? The best surgery is not, there's no best surgery. There's a lot of different goals that each patient has. There's a variety of different techniques available. It's an individualized decision. There's no best surgery for like cookie cutter wise. It depends on each patient, their prior medical history, their prior surgical history, the meds they're on, their entire medical history, their goals, and so much more. So it takes a consultation. This is a giant, a big surgery, a giant decision, and definitely takes. There's no like cookie cutter best option. Great. How long after a revision surgery? How long is recover after a revision surgery? Well, revisions come in so many flavors. It could be a revision from something that's relatively a minor revision, such as like an external feature, like labiaplasty, like revising the labia or revising something externally. And these can take, you might be feeling better in a very short amount of time. Whereas if it's a major depth revision type case, it wouldn't be all that different from the original surgery in many forms. So it might take up to 8 weeks. All right. Do patients feel phantom pain? I've never. I had a patient actually just ask me about that earlier this week for the first time, and I've never had anyone complain of a phantom type pain. So I don't think so, but I have not seen any studies or anything on it in the literature, and I've not had a patient experience it before. Great question. This is the second person in 1 week. Is it possible to regain depth after peritoneal flap vaginoplasty? So peritoneal flap vaginoplasty, when it first was designed, the very first studies, it was designed as a revision technique to revise depth after the only existing full depth vaginoplasty, or the main major one, which was penile inversion. So that was the initial design. Since then, it's become an option for people both at the primary, meaning when they're going for their very first vaginoplasty surgery, or for revision after prior PIV, penile inversion vaginoplasty technique. However, at this point in time, if you've already used peritoneum to augment depth, whether it was in a prior revision surgery or in a prior your primary vaginoplasty technique, doing a redo peritoneal flap is not an option that I can offer at this time. I've definitely heard from colleagues that there's thought that maybe it could be done in the future, but time will tell. Great question. So the only option at that point that I tell patients after they've already done peritoneal, at that point I often recommend that they look for a surgeon who can offer intestinal vaginoplasties most often. But again, that's also another very individual type kind of question that needs to be kind of discussed in the consultation. That's a very complicated question, so definitely something that takes an individual approach. But thank you for the question. I'm going to take a minute to kind of go back into questions. Hi everyone who might be new. I'm Ken in Celtik. I'm a reconstructive urologist here at the Crane Center in California. If you have questions, comments, feel free to drop them in the comments. I see another one. Is vaginoplasty painful? It's major surgery, major reconstructive surgery. And so but is it painful? Surgery is painful by definition. It hurts. A knife is cutting you. With that being said, we take a lot of care to minimize pain and optimize your kind of experience in that regard. How pain is managed starts from the preoperative visit, which is communication about what to expect with regard to pain, how we're going to manage it, both while you're asleep in the surgery, when you wake up and you're in the hospital, and when you go home. Setting expectations is the single best pain medicine. There's plenty of data to even prove that. It's amazing. But with that being said, we manage pain with a multimodal technique, meaning I treat pain with multiple different types of medication, so that we attack it from kind of every angle to help keep it under control. Even in the operating room, I'm putting tons of numbing medication to make everywhere we did surgery numb, and then from there on, we work forward from that. But with that being said, patients are walking the day after surgery, and it's a functional goal. I need pain controlled enough for you to be able to walk, because walking is so important after surgery. Great question. What is the cost for this surgery? And I'm getting a revision, and what is the cost? So cost questions are something that you'd have to discuss directly, with it's basically after a consultation, once we figure out what's necessary. That costs are individualized. Most of our patients use medical insurance, and so if your insurance participates, most people are able to use their existing medical insurance for their care here. Another good question's coming in. Will I require a gynecologist going forward in the future? How do gynecologists feel about transgender women, neovaginas? So in the first 3 to 6 months, I'm your gynecologist, your urologist. I'm here for you. And at that point, you're in the process of healing, and at that point, I'll take you under my wing. We make sure that everything's going well, and make sure everything's going good. But after 3-6 months pass, you're going to be fully healed or darn near. And over the kind of when I talk to patients at 6 months post-op or later, that's when we start talking about getting a local gynecologist. Again, many of our patients aren't local to us here in the Bay Area. They might be coming from out of state or elsewhere in the country, or even outside the country. Plenty of patients coming internationally. And so if you're coming from elsewhere, typically patients will spend between 3 and 4 weeks here in California. And then both before and after that kind of time spent in California, close to us, do a lot of virtual visits. So if you're doing a virtual visit with me, at 3 months out, that or 6 months out, we'll start talking about how to find a local gynecologist. And that'll be an individual process for each of you. Finding someone who's going to be the best person to take care of you from that point going forward. And so, yeah, good question. Typically around the 1 year point is when I have people graduate per se, and move on to their local gynecologist. Good question. And again, in the comments, you can see there's an email available if you have individualized questions or have questions or need any sort of support in any form. Feel free to email us, and we can help arrange that for you. Great questions, thank you. So, for anyone who is new, Dr. Kenneth Celtik, talking about feminizing bottom surgery. If you have any questions, comments, or whatever, feel free to drop them in the comments. I'm going to kind of continue. So, the wrong button. So we've kind of talked about PIV, but kind of moving into another technique for vaginoplasty. We've already talked about minimal depth vaginoplasty, which involves creating all the features of the external vagina without a vaginal canal for receptive vaginal intercourse. We already talked about PIV, which again uses all the external tissues that are available externally to create all the features of the external vagina: the labia majora, the labia minora, clitoris, clitoral hood, recessed vaginal vestibule, and the fold-up vaginal canal. Now, the third technique that we're talking about is called robotic peritoneal flap vaginoplasty. Robotic peritoneal flap vaginoplasty is kind of a iterative, just minor change on that standard, more standard penile inversion technique. The use of peritoneum. First off, peritoneum is the internal lining surface inside your belly. It lines all of your intestines, and it's, among other things, one of its primary jobs is keeping your abdomen lubricated so that your intestines can slide all over each other. So there was first described decades ago the use of using peritoneum to augment vaginal depth. Over the subsequent decades, actually just about 5-6 years ago, a team at NYU demonstrated that using the surgical robot, you could perform gender-affirming revision and primary vaginoplasty surgeries using peritoneum as an augment tissue, as a substitution tissue, which is something that we offer here at Crane Center, California. So, peritoneal flap, kind of getting into it, it involves all the same, for me, it's the same external technique, creating labia majora, labia minora, clitoris, clitoral hood, recessed vaginal vestibule, urethral, opening in the right spot, and the entrance, the introitus, the entrance to the vaginal canal are all made using skin. However, we use peritoneum to augment the depth of the vaginal canal. So how we access that is we do robotic surgery. I'll fill up your belly with CO2 gas till you look like a 40-week pregnant person, make 5 to 6 small incisions across your abdominal wall to allow all the robotic instruments in, and then I'll drive the surgical robot and use it to create your vaginal canal, as well as harvest the flaps that'll be used to make your, to augment your vaginal depth. So, it's an option for some people. It's something that some people find desirable. And what's unique about peritoneum is it makes a fluid called peritoneal fluid. It's a yellowy kind of straw-colored fluid that's a lubricating fluid in your belly. But when we hijack it to make part of your vagina, that fluid is now going to be present inside your vaginal canal. Peritoneal fluid, initially we thought it was going to be the create a self-lubricating, self-cleaning vagina. Unfortunately, that's not the reality. You still have to clean your vagina. Doing douching. Like in other techniques, you still have to dilate your vaginal canal. Still have to use external lubrication for receptive sex and dilation. But with that being said, there is often added moisture in the vaginal canal. Majority of people, it's just moisture that's present. Some people might need a pad. Other people might have less. But it's variable. Anyhow, I'm going to take a moment to kind of take a look at some questions. Good questions. After vaginoplasty, do I have to dilate for the rest of my life? The answer, in short, is yes. Irrespective of what technique you choose, oftentimes the body will try and kind of close down around the vaginal canal, and in order to kind of stop that process, vaginal dilation using external dilators and external lubrication is an important piece of the puzzle. So whether you choose PIV, robotic peritoneal flap, and even in many cases intestinal vaginoplasty, lifelong vaginal dilation every single day is a part of the future. Great question. Why is it required to be on hormones 1 year leading up to surgery? Don't they require you to stop hormones before surgery? Good question. So we follow the WPATH guidelines. WPATH is the World Professional Association of Transgender Healthcare. They've set forth worldwide guidelines for people who are doing gender affirming care in all forms: surgery, medical, and others, and psychiatric. And so their recommendations are that patients are on hormones for 1 year if appropriate medically. So these are kind of the guidelines that are set forth from our kind of our organization, and they're what we follow. What distance we? Okay. And so the next question, I see a good question. It says, what distance from our location would you recommend that we stay? Most patients stay quite close. So most of our surgeries are done in San Francisco proper. With that being said, our office is actually across the Golden Gate Bridge, the beautiful Golden Gate Bridge. But anyhow, we're over in Marin. It's just on the other side of the Golden Gate Bridge in a small town called Greenbrae. And most of our patients stay within about a 3-mile radius of our office here, because although the surgery takes place there, your surgery, you're only admitted for maybe 2 nights, and then you spend most of the time you're in California, coming and visiting us here at the office, once a week for post-operative visits. But most patients stay quite close, but within 30 miles is kind of the norm. There are some local hotels that have are happy to take our patients and give a discount, and so many patients stay quite close. But staying within the larger Bay Area is what's key, just so that if something, I'm all about kind of taking, being kind of conservative, and should something medical emergency happen post-op. I mean, this is major surgery, so if something were to happen, I need you close enough so that I can get you to a hospital where I can take care of you and take care of you. So that proximity is very important. So every patient spends their immediate post-operative few weeks close by. Great question. Is it possible for me to have intestinal vaginoplasty after peritoneal flap? Yes, often, but that's a very individual question, because these types of revision surgeries are always on a kind of a case-by-case basis, because there's so much complexity in a revision case, and so it's something that has to be discussed. Sorry, just looking for the next question. Yep. Okay. Sorry, I see a question. Do I have to stay in California for 3 to 4 weeks if someone is not in the same state because of? Yeah, I hear you. I mean, hotel prices and the cost of staying out here in California can't be minimized. I mean, I hear you. I mean, it's expensive. I'm not gonna sugarcoat any piece of that. But unfortunately, I mean, this is a huge surgery. It has to be taken and respected and taken seriously. Are major complications, that require rehospitalization common? No, not at all. But if they happen, I need you close, because we got to take care of it, and it needs to be done, done safely. So always we'll keep you close by, so that we can, for that first, few weeks after surgery, so that we can make sure that everything's done. How often do rectal breaches? I think you're asking like rectal injuries. There was a study published, relatively recently, where the rectal injury rate, again, the data on rectal injuries is sparse and inconsistent, is probably the best way to describe it. And it seems that depending on the scenario, is it a primary surgery? Is it a revision surgery? These are huge, make it very drastically. In primary surgeries, it seems like rectal injuries may occur at approximately 1%, 1 in 100 rate, whereas in revision surgeries, when we're doing redo surgery, the revision rectal injury rate can be as high as, in some centers in Europe, they've even reported as high as 20%. Now here, that is not our experience at all. Not at all. But with that being said, the data speaks for itself, but with that being said, our experience follows more in line with the 1% or less. Is sexual intercourse a replacement for dilation? Good question. Initially, every surgeon that you talk to, if you talk to multiple surgeons, they're all going to have a different dilation kind of protocol. Dilation protocols are highly variable because there's no science, there's no data to say which one is better or worse. Each surgeon kind of adopts what they feel is their best option. And the reality is time spent with the dilator in is, as far as preventing vaginal stenosis, is the best. So the more time spent with it in, you can't close down a vagina if you got a dilator in. So initially you're going to start off dilating with me, dilating for 4 times a day for the first couple months, and then slowly decreasing to 3 times a day. And again, it's a highly variable. Like, we set down a kind of a protocol of expectations, but not everyone decreases at the same rate, their frequency of dilation. Some people hold on and keep doing 4 for a long period of time. Some people go to 3 sooner than others. It varies with each person. But again, to answer the question, yes. Once you're able to, I ask patients to wait till 3 months to have sex, and after that point, when they start having receptive sex, an episode, like a sexual encounter, will replace 1 dilation session. So if you have sex, again, you get to skip that, session for the day. Great question. Let me take a sip of water. But getting back to peritoneal flap, because again, I'm Dr. Celtik here at Crane Center, California. Here we're talking about feminizing bottom surgery. Feel free to drop any questions you have in the comments. Trying to answer those primarily in first, but to kind of keep things rolling along, I want to talk about peritoneal flap. So this is adapted actually from a publication that was published describing peritoneal flap, and it's in the Journal of Urology. But anyhow, it basically demonstrates kind of how the preoperative anatomy, you can kind of see these color coding areas, and these are skin linings. So here's green, blue, yellow. This is the peritoneum internally, and it shows the bladder, prostate, and urethra and rectum. And so basically what it's demonstrating is where do those, if you follow the colors, like where do the tissues end up? So this is trying to indicate that, like, your perineal skin, the skin between the rectum and the vaginal canal, which is here in purple, is going to form part of the introitus. The shaft skin becomes part of the introitus and part of the external vagina. This green area is the scrotal skin that forms the scrotal graft that kind of is the intermediary, and then the depth of the vagina and peritoneal technique is peritoneum. Anyhow, if anyone has questions, feel free to drop them. There's also other techniques, intestinal vaginoplasty techniques, that I don't offer here at the Crane Center, but there are other centers that specialize in these techniques. They can be used as primary surgeries. They're most commonly used as revision options. And as far as the risks for those types of procedures, definitely something that you should speak to a surgeon who offers those techniques to kind of elicit what those might be. But kind of diving in, another question just came in. What is the best way to fit dilation in your daily routine? So I'm going to answer that first, because sometimes it's that questions I don't answer as well. Initially, when you're in the 4 times a day period, usually that's in your early convalescence, the first couple of months. So 4 times a day, what we ask patients to do is dilate 4 times a day with the dilator in for 15 minutes, which it sounds like only an hour in total a day, but the reality is time to get the dilator full depth when you're first healing and first learning how to dilate can sometimes take even longer than 15 minutes just to get it in, and then you have to wait full 15 minutes. So initially it can be like an all-day affair with doing the 4 dilation sessions. But as you move through, you get better, you get more used to doing everything, your body is healing, everything's less uncomfortable and feeling better. Dilation becomes a lot easier. By the time you're kind of resuming your regular activities, maybe going back to work or school or whatever you do during the day, oftentimes patients are kind of dilating it 3 times a day, and that's 3 times a day is a lot easier to manage with a daytime schedule than 4 times a day. And typically, what I tell patients are, it doesn't have to be breakfast, lunch, and dinner. You can do your first dilation before you get out of bed first thing in the morning. You can do your last dilation right before you go to bed at night, and then all you have to do is squeeze in one right when you get home from work. So that's 3 times a day. They don't have to be equally spaced by any means. It's time spent with the dilator in a day. It's about consistency, just not forgetting sessions, not forgetting whole days without dilation is key. Great question. I feel like it would be hard to keep. Yeah, exactly. You're not going to be doing it at a lunch break in the break room. Yes, that you're absolutely not the first person to think that way, and 100% are not expected to do that. It's like, do your second dilation can be a 5 when you get home or whatever. All right. Do you recommend physical therapy? Great question. Yes. So as someone who does quite a bit of revision work, given that I do peritoneal flap, I've met a lot of people who have had PIV, who have encountered issues dilating, and it seems from my experience, and there's plenty of data to say that patients benefit from peritoneal flap, but more importantly, what I've noticed is that it seems like the pelvic floor musculature, the hammock of muscles that separates basically your pelvic internal anatomy from your external anatomy, we have to create a third hole in it to put your vagina through it. And if those muscles are tense and misbehaving and dysfunctional, dilation can be really challenging, it can be painful, and it can set you up for a really bad time with dilation. So what I ask patients to do is to do pelvic floor physical therapy. These are a special type of physical therapy. We're entirely focused on the pelvic floor, where and meet with one of the a pelvic floor physical therapist pre-op, back home, local to you, because for a few reasons. First off, I want you to start learning how. Another sip of water. How to make a lean, flexible pelvic floor that you're able to control. It'll make dilation better. It can make your urinary habits better for the rest of your life. You can make your bowel movements better for the rest of your life. And there's plenty of evidence it can even make your orgasm more robust. I mean, there's plenty of reasons to do pelvic floor physical therapy. It's a great investment. But most importantly, it'll set you up for dilation. So that when you come out here, in a week after surgery, when we take out your vaginal packing, take off the bolster dressing, take out your urinary catheter, and immediately teach you how to start dilating by having the pelvic floor physical therapist teach you about your pelvic floor and teach you how to be coordinated in controlling it. You're able to relax it so that first dilation session and everyone after will be far, far, far more pleasant than should it not, and sets you up for minimizing your chances for vaginal stenosis, at least in every way that I can try and set you up pre-op, and that's what I'm trying to do. I don't want anyone to need a revision, ideally. Great question, great question. What are the best things I can do now to ensure the best aesthetic after surgery? Being healthy, being healthy overall, doing everything that you would do to be healthy, eating a well-balanced diet, regular exercise, managing any sort of chronic conditions that you have, making sure that they're very well managed and under control. All of these things, a healthy body heals nicely, and that's truly the best way you can optimize your aesthetic afterwards. Because in many ways, you're gonna have your aesthetic. That the reality is every vagina looks different. Everyone comes to the operating room with different tissue. And so everyone's vagina is going to look different afterwards. But the best thing you can do to make sure that you are going to have the best aesthetic is just being healthy. Healthy skin, healthy tissue, heals nicer, looks better, and it works better. So everything you can do to work with your primary care doctors, your nutritionist, your physical therapist, or your personal trainer. Do whatever you can do to be in your just best form. Managing all your chronic conditions. Great question. Well, thank you so much. Okay, can I have a great question? Now here we go. This is the real questions. Can I have an orgasm after vaginoplasty? Yes. In fact, most of my patients at their first post-op visit tell me that they have a sensate clitoris. That they're feeling it already. So, the intention is to maintain the ability to orgasm and have a sensate clitoris there is a risk of loss of ability to orgasm, or loss of ability to, or loss of sensation in the clitoris. This is a risk of this surgery. It's been described in the literature. I've actually not encountered it personally, but it has been described. It can happen. Something to keep in mind, but not something that is a very common occurrence by any stretch at all. So yes, absolutely. Great question. Talking a lot. Thank you so much. So anyone who might be new, I'm Ken Celtik, a reconstructive urologist here at the Crane Center, California, answering questions about feminizing bottom surgery, pre-op, post-op, in the OR, and anything else you can come up with. Happy to talk about all of it. See that we have a little stopping question, so I'm going to take a minute. There are risks. This is a long list because this is a big surgery, and there are a lot of different organs and tissues that are involved in the surgery. And so because there's a lot of different tissue types, there are a lot of possibilities for different ways that those tissues can respond in a less than ideal way. Things that could happen anytime you put a knife to skin: there could be bleeding, hematoma formation. There could be risk. You might even need a transfusion. And it can be it's a possibility. These are very well blood supplied tissues, which means something that for bleeding risk. But then on the positive side, tissue that has really good blood supply heals really well, fights off infection, does well. So it's a double-edged sword in that regard. Oh, I see a question. Does sex feel natural, like a woman feel, or does it feel like an inverted penis? The truth is no one can answer that question. There's no one in the world who can who can answer that perfectly, because no one has both of that scenario. So unfortunately, I can't. Oh, sorry. The question is, does it feel like a natural woman would feel it, or does it feel like an inverted penis? No one can answer that. So I'll have to move on from there. Can I have natural lubrication for my vagina? So the PIV technique doesn't produce any sort of fluid. The peritoneal vaginoplasty technique and the intestinal vaginoplasty techniques both are associated with some sort of lubrication, or fluid production in the vaginal canal. With that being said, peritoneal fluid it doesn't get you away from the need for external lubrication for sex or dilation, but it is moisture present in the vaginal canal. Likewise, with intestinal vaginoplasty, the intestinal segment that's used to create the vaginal depth continues to produce mucus, and often that's forms as a form of natural lubrication as well. Great question. Again, back to like standard risk of any surgery: infection, abscess, sepsis. These are all possibilities. There's a risk of hernia formation through abdominal ports if you have a robotic surgery. Prolonged pain or changes in sensation of the labia, or temporary or permanent loss or changes to sensation is always a possibility. If anyone's had surgery on other parts of their body, maybe top surgery or otherwise, you might have areas around your incisions that also have different sensation that they did pre-op. But with that being said, I've never had anyone come back and say that their changes to their labial sensation impacted their sexuality, because as long as the clitoris is online, most folks have a very a good sex life. We already kind of talked about the clitoris and loss of ability to orgasm. Initially after surgery, the labia will swell up. And everyone who has vaginoplasty, the first few months, there's major swelling in the labia majora. It's normal. It goes away. It just takes a few months to go away. But with that being said, there's a natural healing process that involves making scar, both the scars that you're thinking of on the incision level, but deep underneath the tissue, in the places you can't see at all. Your body scar is a natural part of the healing process. It's actually the final stop in the healing process. And so as you make scar, it'll deposit underneath your incisions, which is normal. But scar can also contract on its own. It can squeeze down, and it might not be symmetric on both sides of your vagina. So it can, and sometimes, in very rare situations, cause distortions or asymmetries in your anatomy that need to be, that might bother you, or it might not. It might be something that doesn't bother you, but is a possibility. Great question. Okay. Oh, are there benefits to getting orchiectomy done before? Great question. So we'll go back to orchiectomy because that was something before a lot of people came on. So orchiectomy is both a part of vaginoplasty. It's just a step in the procedure, removing both gonads if they're present. But it can also be done as a standalone surgery. It can be done before vaginoplasty. It does not burn any bridges if done right. And it's also something that can just be, a bridge, because it serves a very different kind of set of goals for patients often. Often patients are seeking it, maybe it's for dysphoria, maybe it's to get off spironolactone or whatever medication you're using as like a T blocker. It can help in that regard. It's a minimally invasive surgery, same day surgery, minimal downtime. And so it does not, I would say that beyond the benefits I mentioned, doesn't like improve the vaginoplasty in any way. It just also doesn't necessarily take away from it either. Great question. Thank you, Melody. Cool. Great question. Back to just kind of briefly talking about some of the complication risks. The urethra is involved in the surgery, right? We're moving your urethra back to where it belongs. There's always a risk of scar tissue forming inside the actual lumen of the urethra, which is called a urethral stricture. You could always form a fistula, which is a abnormal healing process where you make a hole through your scar, and so now then results in having a abnormal connection between your urethra and your vaginal canal. Could be between the prostate and the vaginal canal, or the bladder and in the vaginal canal. Fistula is a remote risk, but it could happen. Things we talk about like bowel obstruction or bowel dysfunction after surgery is a possibility. You could form fistula, like we talked about. If you have a rectal injury, you could form a rectovaginal fistula as a possibility, which is an abnormal connection between the rectum and the vagina. Again, exceedingly uncommon, but can happen. Injury to other organs nearby is always a possibility in any sort of surgery. Granulation tissue is basically a easily bleeding tissue that can form inside some people's vaginal canal. It's relatively easily treated. Oftentimes we can treat it with just a little bit of medicine in the office. If it's more severe, sometimes we take people to the operating room, put them to sleep, same day surgery, 5-minute surgery, kind of burn it to get it to go away. Some people have prolonged drainage. Sometimes it's intentional in peritoneal flap. The most common risks are wound healing issues. People can have delayed wound healing. They can have separations of incisions. Bits of skin can die. But typically, wound healing complications, mild and moderate ones, tend to not impact the final cosmesis. With a little bit of extra patience, a little bit of extra hygiene, and a little bit of extra wound care, most wound complications heal cosmetically to the point where you'll probably never remember them. Once you're some number of months in the future, you'll forget they even happened. Great question. Okay, I see one more. So I got another question. Will the need to pee sensation move? Like, will I feel like I need to pee somewhere else since the urethra is in a different place? Nope, because the need to pee sensation is coming actually from your bladder. There's basically where your bladder funnels down to the urethra that's going to enter into the prostate. Your prostate's left in place in my technique, and I think most people's technique. We don't touch your prostate or even your more deep part of your urethra. We leave that alone. So your brain, your bladder is going to tell your brain when you got to go pee, and you're going to go pee. The reality is initially after surgery, your urine is going to go everywhere because your urethra doesn't have swelling in it. It's brand new, it's just been operated on, you're going to pee everywhere. But as the weeks pass by, it's going to become a nice directed stream straight down to the toilet. Every once in a while, someone might have a misdirected urinary stream that we can help out. But the need to pee sensation, that's a bladder sensation. It'll stay where it is. Another great question. After a year, do your dilations decrease? Yeah, I mean, even before a year. I work with patients, it's individual basis. We provide a kind of a generic schedule, a protocol of dilation frequency. Initially, people will dilate 4 times a day for 15 minutes. That's for the first 7 or so weeks. Around 2 months out, we'll have patients try and drop one of the dilation sessions to make it more fit into a normal work day, so you can dilate once in the morning, once in the evening, and once right when you get home from work, kind of thing. And then even that decreases. There are people a few months out from months out from surgery who do fine with 3 times a day. They drop one and it's still doing fine. Don't feel like undue tightness, and they may be dilating twice a day. And I've definitely met people who are much further out and they're dilating less frequently than that. So yes, absolutely, great questions. Alrighty. Well, we've talked about a lot of stuff today. I appreciate everyone for coming and showing up, and tons of great questions. I really appreciate it. Again, I'm Ken in Celtik. here at the Crane Center in California. I'm excited to meet everyone. If you've got any questions, feel free to contact us. Our phone number is here. You can always find us at cranects.com. Our phone number is 415-625-3230. Feel free to call. Or if you'd like to just schedule a consult with me, you can go scan this QR code right here. It'll take you to our consultation scheduling page, and we can be happy to have a deep dive into the unique description of what find out which technique is best for you and what's the right path to move forward. I'm also losing my voice, so I appreciate it. Thank you all for coming out. This has been great. Take care. Thank you so much.